RBC cause typically involve are because of the kidney, bladder or ureter. If it is dysmorphic RBCs, it is more of glomerular origin. So they arise from the kidney is what I want to underscore. So this microscopic appearance of the RBC cause is unmistakable. Only thing is you have to be careful. If it is a woman, you need to take a proper history whether at the time of menstruation the sample got collected. But otherwise, if RBC causes are there, you should not leave the patient simply like that. Let's go to the next question. Primary biliary cirrhosis. It is not seen in the case of the pediatric population. It is seen in the case of the elderly, rather 40 to 45-year middle-aged women with pruritus, intense pruritus is a classical presentation is what I want to underscore to all of you. Now what happens in primary biliary cirrhosis basically? There is an increased expression of the HLA class II antigens, and that will make the hepatocytes and the bile duct epithelial cells to become vulnerable to the injury caused by these activated T lymphocytes. That's the reason, doctor, in the primary biliary cirrhosis, association with the HLA DR8 is something that is unmistakable. So how do you like to describe it? It is a chronic progressive cholestatic disease of unknown etiology, presumed to be of autoimmune origin, and it leads to a progressive cholestasis, and a point of time end stage liver disease will occur because of this, and it is commonly seen in the women, not in the pediatric population, and those women who are between their 4th to 6th decade. So middle-aged women is the classical presentation of the PBC is what I want to underscore. And CVD stones and the ERCP, they are the two important causes for the cholangitis, but not the what you call primary biliary cirrhosis. So that's the reason cholangitis is caused by PBC, that too in children. There are two lies about it. So that's the reason it is not caused by the PBC is what you need to basically remember. Let's go to the next question. Addison's and Cushing's. So endocrine physiology, pharmacology, and these are favorite questions, doctor. You can see in this paper totally about 3 questions came. One on thyroid malignancy, Addison's disease, Cushing's disease. So that's the reason you are going to master this year. We will be starting the session on medicine in the month of June. So that time I'm quite sure that we will discuss these areas more detailed. So Addison's typically pigmentation is a classical feature, doctor. Note the generalized pigmentation, but especially along the creases, nails and gums is a classical area where in Addison's there will be pigmentation. There will be asthenia, abdominal pain, but not hyper. It is hypotension is what I want to underscore. So continuously you are dumping a lot of saline, but still the BP is not improving. In an individual who is totally emaciated and he is totally hyperpigmented, like a negroid complexion is there, you should think of the possibility of the Addison's. You need to send the steroid. Commonly, what is the cause for the Addison's, doctor? Adrenal destruction of autoimmune origin or because of TB in this country? TB is a very common cause, is something that should not be basically forgotten. Salt losing nephropathy typically seen in the case of the interstitial nephritis. Interstitial nephritis can be acute, it can be drug induced, where there will be no changes in glomerulus, only changes in the tubulointerstitial compartment is what need to be basically remembered. And the glomeruli here are not showing any pathology. What you are finding only in the interstitium, where there is an expanded fibrosis is what I want to underscore to all of you. Let's go to the next question. Once our favorite question. Electrolytes are the rats that roar like lions when it comes to mortality. There's a reason, doctor, as a good physician, you should not forget to ignore not ignore the electrolytes, sodium, potassium. So invariably, how many questions came on electrolytes, doctor, in this exam? 4 questions came on electrolytes. Hypokalemia, 1 question came. Hypernatremia, another question came. That's the reason let us master this important topic. Hypernatremic dehydration. What happens with the hypernatremia is my question to all of you. Before that, what do you mean by isonatremic, hypo and hypernatremic dehydration, doctor? When the sodium is 130 to 150, it's called isonatremic, less than 130, hypo and greater than 150 is called hyper is what I want to underscore. Generally, you come across isonatremic dehydration commonly in our clinical setup. Now, in the case of a hyponatremia, chronic hyponatremia, if you collect more than 2 milliequivalents per liter per hour, for example, my sodium value is about 120 milliequivalents per liter. I am a hyponatremic individual. Normally, what is the value? 135 milliequivalents per liter. You want to correct my 120, don't correct more than 12 milliequivalents per liter in one day. That means tomorrow when you check my sodium value, it can at max be 132 milliequivalents from this 120, but not more than that. Suppose if you correct my so-called hyponatremia more than about 10 milliequivalents, 10 to 12 milliequivalents per liter per day, then I'll be landing in a condition called central pontine myelinolysis is something which you should not basically forget. What is central pontine myelinolysis, doctor? Typically, what is the purpose of the pons? The pons is the area where all the efferents of the body will be going. So there's a reason, doctor, they receive all afferents but they can't efferent. So by the day next you see the patient, he will be like a frog situation. He can't be able to talk, he can't be able to move the limbs. So this kind of dead frog-like appearance is seen because the central pontine myelinolysis, which is otherwise called the deferented syndrome, is what you have to basically understand. Why will it occur? If you correct the hyponatremia greater than 12 milliequivalents per liter per day, then this complication can occur is what need to be remembered. So there's a reason, doctor, it is not seen with the hypernatremic dehydration at any cost. Now let us talk about the hypernatremic dehydration. Typically, in the hypernatremic dehydration, the water is osmotically pulled from the cells into the extracellular space, because who is there in the extracellular space in hypernatremia? Lot of osmotically active sodium is there. It will suck all the water from the cerebral tissue. So rapidly it will suck the water that the cells become shrunken and it can predispose to cerebral hemorrhage if this dehydration and the hypernatremia are developing very fast. So that's the reason cerebral hemorrhage can occur. Number two, this kind of hypernatremia, suppose while you are rehydrating, if you happen to do it very rapidly while treating this, what is the treatment of hypernatremia? Hypernatremia, commonly patients will have a dehydrated state. So you need to immediately create that water deficit which is there in their body. If you do it too aggressively, then what will happen? That can lead to a severe cerebral swelling and that lead to cerebral edema. There's a reason, doctor, cerebral hemorrhage can occur as a complication of the hypernatremia in an untreated patient, and cerebral edema can occur as a complication in an over-jealously treated patient is what need to be remembered. That is the story of hypernatremia. But hyponatremia, if corrected rapidly, can lead to central pontine myelinolysis is what I want to underscore. Can anybody give what is the fourth option given in this? Metabolic acidosis is one more thing which had been added to this. So generally dehydration must lead to development of secondary hyperaldosteronism, which should lead to metabolic alkalosis. So shall we put that as the answer? But whatever, I am not very clear about why he placed central pontine myelinolysis. By that basis I may consider, but you can also give if you have any clue about this particular question. But definitely these two are associated with the hypernatremic dehydration. I am very sure about A and B. Let's go to the next question. But before that, mild dehydration, how much you need to give the water replenishment, doctor? Fluid replenishment, 50 ml per kg in infants. Moderate dehydration, 100 ml per kg. Severe dehydration, 150 ml per kg. That's the reason if you have got a 2 kg, 3 kg child, you can give at most 3 into 150, 450 ml, one normal saline bottle must run. But you must be doubly sure how will one normal saline will run over 24 hours. So for that you need to know how to calculate the drip rate. Anyway, we will take in a different session. What is the side effect of leflunomide? I like to ask a question. Leflunomide, typically which condition do we use? Erosive form of the rheumatoid arthritis is what need to be basically remembered. So the most commonly reported side effects of the leflunomide are diarrhea, nausea, headache, rash, itching and the loss of thinning of the hair and a high blood pressure, chest pain. They are all the major problems. One more important thing is leflunomide basically is an immunomodulator. That's the reason it can suppress the immune system, hence those individuals are more vulnerable to develop the infections of the respiratory tract. That's the reason you need to be careful while giving the leflunomide. One more important adverse effect is it can lead to liver damage, hepatotoxicity. That's the reason it can lead to the liver enzymes to become elevated. Hence every time before you start the leflunomide or the anti-tuberculous therapy, you should not forget, especially in the background if the patient is alcoholic, in the background he had a viral hepatitis, he has got some other risk factors which already had damaged his liver. You should not forget to send the liver function tests is a very important habit that you have to make as a house surgeon while sending the ATT. Even leflunomide if you administer, check for the LFT. So serially while leflunomide is administered, serial values of the LFT need to be checked. But leflunomide should never be given in pregnancy because it is very well known to lead to teratogenicity is what I want to underscore. That's the reason, doctor, before you start leflunomide, Suppose if the woman is in a reproductive age group, you need to take a proper history of her reproductive, her menstrual cycle, so that you need to be careful, because leflunomide can lead to teratogenicity. Let's go to the next question. Our favorite area has come, doctor. Cardiology, invariably you will have 3 to 4 questions invariably, hence you have to master this, doctor. Pulsus bisferiens, typically where is it appreciated? It is the carotid artery where it will be better appreciated, is what need to be remembered. What is the reason for this? Because the carotid is very similar to the central aortic pulse, because it is very closer to the aorta, very nature of it is very closer, is what I want to underscore to all of you. Hence it gives a more accurate representation, is what I want to underscore. For what purpose do we use the brachial artery and the radial artery, doctor? It is for the pulse volume, to know the consistency of the peripheral vessels. You will be doing the brachial artery examination, is what I want to underscore to all of you. Whereas if you want to know anything about the left ventricular ejection velocity, similarly how is the stroke volume, is it adequate or not? Similarly, if you want to know about the aortic valve function, in all these situations it is always better to check, rather not better, it is compulsory that you check only carotid, is what I want to underscore to all of you. Now, what is this pulsus bisferiens is my question to all of you, and what is the difference between pulsus bisferiens and the dicrotic pulse, is what I like to ask. Usmania Medical College means you are all thrills of clinical medicine and clinical posting, because one of my friends, Foreddy Sampath, is also from Usmania, from when I joined Nizams in general medicine. So in the first year in MD, I used to not know what is S1, what is S2 and all these things. Whereas that fellow already mastered what is decapitation of the aortic systolic pressure, in aortic stenosis, everything. He is an encyclopedia of clinical medicine. I asked, what is the secret for that? He used to say, oh, Usmania means you are considered to be champions, you can't escape good housemanship, good clinical posting. Now I like to ask a question to all the stalwarts here. We'll target Ravikant once more. Tell me, doctor, what is pulsus bisferiens? Typically, bis means twice, feriens means beating. There are 2 systolic peaks which will be occurring in the case of the pulsus bisferiens. It occurs in 2 important conditions. When will the heart produce 2 beats only in one single systole while it is vomiting the blood into the aorta? If there is any HOCM, why in HOCM, doctor? Because there is a dynamic obstruction for a systolic outflow in the hypertrophic obstructive cardiomyopathy. That's the reason, doctor, because that obstruction 2 peaks will arise, is what need to be basically remembered. So that's the reason, doctor, in a severe aortic regurgitation and the aortic regurgitation with stenosis or with the HOCM, you come across the bisferiens pulse, but here the 2 peaks are there within the systole, is what need to be remembered. Whereas in the case of the dicrotic pulse, the second wave that you see is not in the systole. One is in the systole, the second wave is in the diastole, is what I want to underscore.